Hello, I am Dr. Ellen Morrison. I am presenting validation of the Stoplight Pain Scale tool in the Canadian Emergency Department setting. Funding for this study was provided by Women and Children's Health Research Institute at the University of Alberta. Dr. Amy Drendel co-created the Stoplight Pain Scale tool, which is available on an open access format. The authors have no financial relationships relevant to this presentation. Pediatric pain is common and undertreated. Acute pain is a common presentation to pediatric emergency departments, with over 60% of all presentations having pain as part of the chief complaint. Pain is not well managed in the emergency department or at home, with 65% of children who rated their pain as moderate to severe receiving no pre-hospital analgesia, and only 40% of children with a painful chief complaint receiving analgesia in the emergency department. Barriers to improved pediatric pain management include parental perspectives on how children express pain, such as the expectation that children will explicitly ask for analgesia, and physician difficulty in assessing pediatric pain, particularly in younger children or for physicians who rarely see pediatric patients. Our objectives are to validate the Stoplight Pain Scale. First, is the Stoplight Pain Scale a valid measure of acute pain when compared to the FACES Pain Scale revised among children aged 3 to 12 years presenting to the pediatric emergency department with a painful complaint? Second, is the Stoplight Pain Scale responsive to changes in the patient's level of perceived pain? And third, which pain scale do caregivers and children prefer, the Stoplight Pain Scale or the FACES Pain Scale revised? We completed a prospective observational cohort study at the Stoplight Children's Hospital Pediatric Emergency Department in Edmonton, Alberta, Canada, from November 2014 to February 2017. We enrolled children aged 3 to 12 years with an acute injury presenting to the Pediatric Emergency Department and requesting analgesia. The enrolled children and caregivers were asked to rate their pain at presentation, following a painful procedure, and 30 minutes after analgesia. Of note, we collected scores for the children and for the caregivers separately. Pain was rated on 3 scales. Child and caregiver preference of scales was also recorded at the end of their emergency department stay. This is the Stoplight Pain Scale, which uses the traffic light or stoplight construct that would be very familiar to preschool and school-aged children. Green means go, I am okay, and I feel fine. Yellow or yield means I'm not sure, please ask again later. And red means stop, I hurt, I need something to feel better. The FACES Pain Scale revised rates children's pain from 0 to 10 with 6 different faces the children can identify with. The Baxter Retching Faces Scale rates children's nausea from 0 to 10, again with 6 faces that they can recognize themselves in. We enrolled a total of 227 children in our study. We theorized that the stoplight construct would be most attractive to preschool-aged children, and so we did do subgroup analysis looking at our 3 to 5 year patients, as well as our 6 to 12-year-old patients. We also theorized that children with previous painful admissions would probably have seen the FACES Pain Scale revised previously and may have a preference for that, and so we did follow them separately. We assessed that a score on the FACES Pain Scale of 0 to 4 would correspond with the green face, or I'm okay. A score of 6 would correspond to our yellow face of I'm not sure, ask me again. And a score of 8 to 10 would correspond to our red face of I hurt and I need something to feel better. Convergent validity refers to how well 2 tools or scales, which are meant to measure the same thing, actually do agree with each other. So we compared the Stoplight Pain Scale to the FACES Pain Scale revised. At presentation, the child scores for those 2 scales had fair agreement with a Cohen's kappa of 0.28. The caregiver scores at that same time had poor agreement. 30 minutes after analgesia, again, the child scores had fair agreement between the 2 scales, whereas the caregiver scores had poor agreement. After a painful procedure, both the child and caregiver scores had fair agreement when comparing the Stoplight Pain Scale and the FACES Pain Scale revised. Discriminative validity refers to how well a tool measures exactly what it wants to measure and not something that is somewhat similar, which is why we compared pain with the Stoplight Scale to nausea from the Baxter Retching Faces Scale. At presentation, both child and caregiver scores showed no agreement between those 2 scales. 30 minutes after analgesia, again, child and caregiver scores showed very poor agreement between those 2 scales. We were also interested in how well the child score and the caregiver's score actually agreed with each other. At initial presentation, both the Stoplight Pain Scale and the FACES Pain Scale Revised had fair agreement between the child score and the caregiver's score, whereas the Baxter Retching FACES scale had only poor or to fair agreement. 30 minutes after analgesia, again, the Stoplight Pain Scale showed fair agreement between child and caregiver scores. After a painful procedure, this improved with the Stoplight Pain Scale showing moderate agreement between those two scores, while FACES Pain Scale Revised still showed only fair agreement. Responsiveness refers to how well the scale is able to recognize changes in the child's state, such as improvement in their pain after receiving analgesia. At presentation, a total of 41.2% of our children and 53.7% of the caregivers rated them as having a red face or very painful situation. And 30 minutes after analgesia, we did see that number decrease substantially to 24.7% of children and 19.7% of caregivers. Similarly, at presentation, the mean FACES Pain Scale Revised score was 5.1 for children and 5.2 for caregivers, which would place them somewhere in the green to yellow zone on our Stoplight Pain Scale. After analgesia, they did improve to 3.4 for children and 3.1 for caregivers, placing them well within our green face or green zone, showing that both scales did show a decrease in pain following analgesia. In terms of preference of pain scales, both children and caregivers preferred the Stoplight Pain Scale to the FACES Pain Scale Revised. Interestingly, the age of the child did not change how much they preferred the Stoplight Pain Scale, with 76.6% of 3 to 5-year-olds and 71% of 6 to 12-year-olds preferring the Stoplight Pain Scale to the FACES Pain Scale Revised. Interestingly, previous hospitalization showed no change in how likely they were to prefer the Stoplight Pain Scale. In terms of caregivers, again, a majority of them did prefer the Stoplight Pain Scale. However, for caregivers of younger children, it was even a more marked preference, with 77.8% of caregivers of 3 to 5-year-old children preferring the Stoplight Pain Scale, and only 53% of caregivers of 6 to 12-year-olds preferring the Stoplight Pain Scale. In conclusion, the Stoplight Pain Scale had fair convergent validity compared to FACES Pain Scale Revised. Stoplight Pain Scale showed excellent discriminant validity compared to the Baxter Retching FACES scale. Stoplight Pain Scale showed fair agreement between child and caregiver scores. Recurrent exposure to the scale showed improved agreement between child and caregiver scores. And the Stoplight Pain Scale was preferred by both children and caregivers. We believe that a pain tool or pain measurement tool must be simple, practical, age-appropriate, and reliable. And the Stoplight Pain Scale tool is all of those. In addition, unlike any other pain assessment tool currently available, the Stoplight Pain Scale tool is action-oriented with a specific recommendation for parents and healthcare providers in what to do when they measure their children's pain. Looking forward, we believe the Stoplight Pain Scale tool could be very useful as a tool for repeated assessments, such as on inpatient units and hospitals. The Stoplight Pain Scale can also be used in non-pediatric settings, such as pre-hospital transport or emergency medical services, as well as in hospitals that are more general hospitals that occasionally admit pediatric patients, but have less familiarity with them as a patient population. And finally, we are very interested in the Stoplight Pain Scale at home, particularly for children discharged home after a painful procedure or diagnosis. I would like to acknowledge my co-authors, as well as the research assistants and volunteer research students, and thank all of the children and caregivers who participated in our study. Thank you.